Good morning, everyone. Welcome to Grand Rounds. It's my great pleasure this morning to introduce our speaker, Dr. Ateev Mehrotra. Dr. Mehrotra received his MD degree from the University of California, San Francisco, where I was fortunate enough to be one of his classmates. He completed his residency in internal medicine and pediatrics at the Massachusetts General Hospital and the Children's Hospital of Boston. He also received a Master's of Public Health from the University of California, Berkeley, and a Master of Science degree in Epidemiology from the Harvard School of Public Health. Dr. Mehrotra is a professor of healthcare policy and medicine at Harvard Medical School and a hospitalist at the Beth Israel Deaconess Medical Center. His clinical work has been both as a primary care physician and as an adult and pediatric hospitalist. His research is focused on delivery innovations such as retail clinics, e-visits, and telemedicine, including their impact on quality, costs, and access to healthcare. He's a well-funded investigator and has also published numerous peer-reviewed articles. He was the 2020 recipient of the A. Clifford Barker Excellence in Mentoring Award and a 2020 Fulbright Scholar. Dr. Mehrotra will be speaking to us today about the impact of the COVID-19 pandemic on telemedicine use and healthcare delivery. Thank you, Dr. Mehrotra.
Thanks so much. And thank you to all the people in the audience for joining on a early in the morning your time as well, right before the holidays. I know everyone's so busy at this time of year. Before I begin with the talk and the slides, I was asked to comment a little bit about more on a personal side, what drives why I do this work. I was reflecting on that, and I think it's like two very competing emotions. One is hope. I'm getting old enough, and I've seen the current delivery system that I've practiced in for almost 2 decades, and frustration with it. You know, every study we do shows often lack quality. We see access barriers, disparities, a lot of burnout among clinicians, and just a hope that we got to find a new way of delivering care to try to better deliver we all have new drugs and new devices, but how do we actually provide care needs to change. And until the pandemic, I hadn't seen a lot of that change. So that's the hope part. And then the other part that it competes in my mind, the other thought that's in my mind is cynicism. I've been also doing this a while, and I've seen that a lot of these great ideas that people are going to do something new don't work. That's just the nature of medicine. And it's a lot of hot air. And I get a little annoyed that a lot of the delivery innovations that I'm going to describe to you, we just kind of do it. We don't rigorously test whether this new device, whether this new delivery system, this new app really makes a difference as we do with drugs and new devices and so forth. So it's this competition between hope that we can find a new way, but also cynicism and recognition that many of the things we're going to try aren't going to work. My hope in the research that I do is I can, as best as I can, try to provide a little balanced perspective on what is working and what isn't working, and how do we change the payment and regulation environment to really facilitate that. And it's a nice transition to the talk at hand, which is really about the COVID pandemic and telemedicine use specifically, or telehealth. I'll use those terms interchangeably. You know, I was, before I got on, I was reflecting, so what did I want to cover today? What the heck happened in telehealth during the pandemic? I'm going to raise questions and not give you many great answers, but try to address, I think, a critical question. Did all this change make a difference? Is it good? Is it bad? And then when I speak to my fellow clinicians, there's often a lot of questions about where the heck are we going? And I'm going to raise and discuss with you a lot of the ongoing debate, both at the federal, state, health plan, health system level about where we're going with the future of telehealth or telemedicine. So what I thought I would do is, I was reflecting with Simmerjob that we're almost 2 years into this. And that's both scary and kind of, it's amazing that we've been working on this. So I thought I'd remind me of where we were early in the pandemic, because it does reflect a lot of the impetus for going to telehealth. This was a piece in May of 2020 in the New York Times, and really talking about the fear of COVID and how patients were just scared to get care. People are saying, I'm having a heart attack, I'm going to stay home, I'm not going to die in that hospital. And one woman who was in getting treatment for cancer said, every time she has to go in for a scan or blood work, I have a borderline meltdown. People, and we remember, we're trying to avoid anything to avoid the healthcare system. And I think that reflects in the changes that we saw immediately right after the pandemic. This is some work that we did tracking the pandemic. We just kept on releasing reports because there's a lot of interest in what visit patterns were like in the United States. These are data from roughly 50,000 providers scattered across the United States. And on the x-axis is the months of the year, weeks of the year. And in 2020 is the orange line, and blue is the kind of typical thing we would see in a year relative to a baseline week, and what we all experienced. Early on in those first couple of weeks of the pandemic, this dramatic, almost 60% decline in outpatient visits per week, every week, though that rapidly rebounded, and I'll kind of give you some graphs about where we've been since that point. And I think all of you on the call reflected on this change, and at least if you're like me, had this, oh my gosh, what's going to happen to our patients with chronic illness? What is going to happen to acute needs outside of COVID when they have it during this period where no one is getting care? I also just thought I'd reflect on the fact that it wasn't a homogeneous change that we had. You can see for behavioral health providers, a much smaller decline than say for something like ophthalmology, where it was almost down to almost 80%. So just reflective of the variation by specialty, clinical area, type of care. This was reflected in hospitalizations, cancer screening, surgeries, everything declined. I make a quick note that the one positive group that's going to get into this, and something that isn't reflected a lot, is that healthcare spending in the United States fell dramatically, and health plan profit margins went way up during the pandemic because of the lack of care, and something that hasn't been addressed enough. And I'll maybe get back to that a little bit later. Okay, so that's all just general care, but I bring it up because people saw that, and understandably, everyone had the same reaction. We need to get our patients access to care. And this idea that the future of telemedicine, which is going to be telehealth, suddenly became the norm. And all of you learned on the fly how to provide a telehealth visit. And if you're like most people, never had done this before. Policymakers implemented so many changes to facilitate telemedicine use. For the first time, most of us could provide visits in the home. We started waiving out-of-pocket costs. We said all patients, not rural residents. We waived all sorts of licensure requirements that I'll get back to a little bit later. And the type of care that who could provide that care was also rapidly expanded. One of the things that in my work, there's this constant belief, like research study after research study, clinical experience said, man, we are slow to change in healthcare. Everything, it takes 10 years, 15 years for anything to diffuse. And I thought the embrace of telehealth in the US healthcare system really challenged an idea that had been very much, sort of accepted. Because within a span of weeks, huge expansion of telehealth in the United States. This is the weeks of 2020, and this is the virtual visits or telehealth visits as a percentage of total baseline visits. So all of a sudden, if you take the usual number of visits in a week in the United States, all of a sudden up to 12% of those were provided via telehealth. There's been a decline, and I'll show you some trends since then. So we're still trying to figure out where we're going to end up with this, but reflective of your own personal experience. I'll mostly focus on the United States in this conversation, but I also just want to reflect that this change that we had in the United States was reflected all over the world, from Europe to here to Australia and in Canada, where the embrace of telehealth was even much larger than it was here in the United States. One thing I'll also discuss a little bit later is that it sounds really fancy and cool to say telehealth, but a lot of this is phone calls. And phone calls doesn't sound great, so we've rebranded phone calls as audio-only telemedicine visits. And I think there is also an interesting debate, both here in the United States as well as worldwide, how much of a role of phone calls is there? We've been providing phone calls for decades in the United States. It was always something that a clinician did for free. And all of a sudden during the pandemic, we started paying for it. And there is this active debate about whether we should continue to pay for those visits or not. I also wanted to reflect that besides the variation across clinical areas, there's also variation geographically. We see in some areas of the Northeast where there was the highest density of telehealth use, huge swaths of the nation where telehealth use has been relatively minimal throughout the pandemic. And then also some areas of California, obviously, where there is greater use. So it is not something, one of the things that we have to always be careful of in healthcare is that in the Boston community, everyone's like, everyone's doing telehealth, it's the norm. Well, that's not really the case. In many areas of the country, there has been relatively minimal use. I also just wanted to highlight the fact that there is variation also by clinical area and types of conditions, as I'll get back to. And I think we all know behavioral health has really embraced telehealth, and it really has now still maintained as the majority of the visits that are provided in the United States, while some other areas such as cataracts and musculoskeletal pain, it makes sense. It's hard to provide telehealth, and there's relatively little telehealth. That's on the x-axis here, and the y-axis is the change in number of visits we've had from pre-COVID to COVID. And again, areas that provided less telehealth, we saw a much greater decline in visits. As I alluded to just a second ago, as I've been describing this change, big variation by clinical area. The behavioral health providers, our psychiatrists, social workers, psychologists, now still in 2021, the majority of the care, this is data from 2020 last year, but into 2021, the majority of the visits are still provided via telehealth, while in many clinical areas, including our surgical subspecialty colleagues, it is relatively rare for them to provide a telehealth visit. And so just to, again, emphasize that point. So that's all the video visits and the phone calls. I also want to reflect on the point that telehealth, that's just a small sliver of how we can use technology to treat our patients. And we are seeing less common still, but a huge surges in other forms of telehealth. The use of e-consults to get specialty care, telemedicine within emergency departments for mental illness and stroke care, big surges. We're seeing also large increases in the use of telehealth. Another form of telehealth is remote patient monitoring, where our patients have blood pressure cuffs and glucose monitors and weights that are all connected to the internet, and physicians get on a monthly basis an update on all of those through Bluetooth connections, et cetera. And we're seeing a lot of use of that, at least among some primary care providers. One other form of telehealth that doesn't get is also kind of doesn't maybe get the same attention as it should is portal messages. Almost all primary care providers in the United States now provide an opportunity, and also many specialists provide that opportunity where a patient can go onto using Epic or whatever other electronic health record platform and send a message to their clinicians. Questions on medications and other things. And one thing that it's a great way and a service that we provide to patients. We've always provided for free. Attention I'll bring up in a moment in a second. And again, not surprisingly, during the pandemic, we've seen a big surge in this. These are data from Epic across 300 large health systems in the United States, showing the relative change in portal messages from pre-pandemic to post-pandemic, and about 150% from baseline where we were. This has caused a lot of issues for clinicians. A lot of my colleagues, and I'm sure many of you in the audience have had that experience where you're spending a lot of time at night answering all these portal messages. Again, patients appreciate it. It's a useful way of providing care, but that time is not being paid for. And so how do we change the US healthcare system to, facilitate this? Or do we make other changes so we discourage the use of portal messages? Certainly some health systems have started to do so. The last piece I wanted to do in these kind of descriptive just graphs here is to also highlight that everyone recognizes that telehealth really surged during the pandemic. I think what is under-recognized is that from that peak, we've come a long way down. So these are from the Medicare program, the number of telemedicine visits per week pre-pandemic. There was around 200,000 or so, huge surge, tenfold increase up to about 2 million visits per week. But subsequent to that point, we've seen a roughly 60% decline in telehealth. This is through April and May of this year, and that decline continues. I think it raises this interesting question of where are we going to kind of level out? I think it's clear that we'll be leveling out at a higher level than we were prior to the pandemic, but exactly where we're headed is a little unclear. Because I do a lot of work in telehealth, I'm asked a question by my clinical colleagues, policymakers, people in Congress. Okay, we made this huge change. Delivery, what the average American experiences now, with more than 50% of Medicare bennies at least having one telehealth visit during the pandemic, has it made a difference? It's a very reasonable and valid question, but as a researcher, a very difficult one to answer. And I'll just highlight some of the things that we found. But again, I don't know if I'm going to definitively answer that question for you. To remind you again, the fear that was out there and the reason we embraced telehealth so quickly, because we wanted to help our patients. So we've done some work on this. I'll show you some work that we published a little bit earlier this year, say in diabetes care. Let me kind of walk you through this. On the top left is the fraction of people with diabetes who are getting care in a given week. And we broke it up into pre-pandemic, early pandemic, and then later in the pandemic. In this lighter green color is 2020, and in dark green is the year prior. So we found that, again, what we all experienced, there was a really rapid decline in the fraction of patients who with diabetes who were getting care. But interestingly, a little bit surprising to me, it kind of got back to normal, and it was a little bit less throughout that time period. And so that's reflected in this relative change. So big decline, in this case, about 45%, but then kind of coming back to where we were previously. And somewhat reflected also in the fraction of patients who had a hemoglobin A1C. Now, the fact that so many of those visits were provided via telehealth, 24% early in the pandemic, 13% later in the pandemic, gives us face validity that this was key for maintaining this access for our patients. And also interestingly, then the question is, did we see a negative effect on glucose control and medication use? What we find for medication use of patients among patients with diabetes, early peak right in the pandemic when there was a lot of panic. Our most often clinicians were telling their patients, go make sure you get your medication filled quickly in case you can't get it later. And then surprising to me, because I had been expressing so much concern about how this pandemic would affect people with chronic illness, in terms of medication fills, rock stable as far as we have seen, and this has been echoed in other chronic illnesses. And when we looked at hemoglobin A1C levels, no change. I think it's been very interesting. I'm obviously very pleased that we have not seen this negative effect here and in other conditions, but also somewhat surprising given the visit disruption we saw previously. And then, the natural conclusion is that telemedicine likely was key to preventing these disruptions, but I don't know if that's a true causal argument. And I won't go into too much detail, but we've looked at all sorts of other disorders. I'll just provide some examples with opioid use disorder, where we wanted to see whether we were concerned that patients who were on buprenorphine or other treatment for opioid use disorder would have a disruption in their care and potentially could have worsening. So we took patients who were already on treatment, and we didn't really, in terms of visit patterns, we didn't see that much of a decline, surprisingly, though a lot of that care was provided via telemedicine. And in terms of medication fills, surprisingly, we found that it was very stable from 2020 to 2019. Again, consistent with what I showed you for diabetes. And this was a particularly disadvantaged population, or population we were very worried about. So again, these are just small snapshots in terms of the questions at hand, in terms of a very basic question, which is we transformed the way that we were delivering healthcare. Did it make a difference? It feels like it is, seems like it has, but I don't know if that definitively answers the question, and we're going to continue to learn about that in the coming months and years. So then the question is, after that, is where the heck are we going? As most of you are aware, with the newest variant emerging, it seems even farther away, there's a little active debate ongoing for the past year, is where should telehealth be? What should we have as post-pandemic telehealth policy? In how should we both pay for it, regulate it, et cetera? And let me outline for all of you some of the key issues in that debate. The first thing that, and I want to emphasize, and I'll also come back to this a little bit later, is that there is just tremendous uncertainty. Everyone's still trying to figure this out. And I've been really surprised and struck by the variation across health systems. I don't know exactly what the UCSD or the VA leadership is doing in your community, but in my conversations with other health systems, I've heard many times from CFOs as well as chief medical officers saying, get our clinicians back in clinic. We had the biggest financial hit of our lives last year, and we need to get our clinicians back to clinics, seeing patients in person, and get that revenue back. I don't know what's going on with this telehealth thing, and it just seems really uncertain. And they've put caps on the amount of telehealth visits that their clinicians might provide. On the flip side, I've heard other large, big academic health systems taking the exact opposite approach, which is, we need to go. This is going to be the future, and we're going to need to increase use of telemedicine across all specialties. Hey, you know, those clinics that aren't, are cardiologists or gastroenterologists, they're not using telehealth enough. They have to have minimums. And we need to, quote, monetize non-reimbursed care. You know, those portal messages that you're spending all night working on, we need to convert those to e-visits and get those billed. All those phone calls, you make sure those are audio only telemedicine visits, and stop getting all those blood pressure measurements via the portal or anything else. Let's get our patients on remote patient monitoring. There's all these mechanisms to increase revenue, and this is going to be really critical. And I'm really embracing the remote patient monitoring. It's something I've heard a lot about in the last couple of months. We'll see who, it's very unclear which of these two strategies is going to be the right one financially. And I, want to recognize that there's all sorts of problems with this strategy. While it obviously makes sense for a health system to try to increase their revenue and make sure that they're financially sustainable, it also creates problems for our patients, because all of a sudden you're hearing complaints out there already where I contacted my primary care provider via a portal message, and all of a sudden I got a bill in the mail for $60. What the heck is an e-visit? Isn't that free? Or all of a sudden I've been calling my doc for decades, and now all of a sudden I have to pay for that. And so how do we explain to our patients that what's free, what's not free, when do they have to pay for it out of pocket, has all become very complicated all of a sudden because of these new changes. In some pieces, we've tried to describe some of what should the post-pandemic regulatory and payment landscape look like. And I want to start with the balancing act. Many of my clinical colleagues say, look, this telehealth thing is awesome. Got to call my patients. I'm seeing no decreases in no-show rates. What's the problem? Like, why don't we continue it? What's Congress's problem that they just don't permanently expand it, and let's just move on with life? And so let me highlight the flip side of this, why the Congressional Budget Office, MedPAC, many others are worried about broad expansion of telehealth. And it's the point that the potential to improve access care must be weighed by the risk of increased spending. That telemedicine's ability to make care more convenient and more accessible, the key to its enormous potential to improve the health of many patients, may also be its Achilles heel. And I'll get into that in a little bit, what people are talking about. I also do want to emphasize before going into this a little bit that the question that I'm often posed is telehealth working? And I'm not sure that's a really fair question. If I went to any of you in the audience and said, some policymaker, some health plans say, do drugs work? You'd struggle to answer that question. Which drug? Which patient? What is the clinical scenario? And then I can tell you if the particular drug is effective or ineffective, and whether it's improving health or the side effects are too high or the costs are too high. And so that's really another thing that we're going to have to think about with telehealth, is to have a much more nuanced view on how we're deploying it. So let's go back to the spending question and explain why there is this concern. When we think about what the impact of telehealth on healthcare spending, a big key question is how much of the care is additive versus substitution. If the care is just substituting for an in-person visit that was already going to happen, no biggie. We're just going to have the same number of visits. It's more convenient for our patients. This is great. The concern really is that a lot of the telehealth care is additive in the sense that someone who otherwise would not have received care is getting care. We'll get back to this, but it kind of alluded to earlier. If it's a new condition where they can really help them, no problem. We provide care because we actually hope to help our patients. But the concern is a lot of, quote, low value or unnecessary visits are happening, and that's going to drive spending up. There's also a lot of debate about how much we should pay for telehealth visits. California, for example, has passed telehealth parity laws that visits must be paid for at the same rate as an in-person visit. And so how much we pay for telehealth is also going to impact its spending. And then also the hope is that telehealth might deter long-term complications. And so this impact on downstream costs is another aspect of this. But let me talk about a little bit more on this first issue. And go back to a piece that you might be familiar from the New England Journal from several decades ago, which is on the ecology of medical care. This is a very basic idea in this study where they took patients in the United States and the United Kingdom and described how many people in a given month get sick. And of those people, how many actually get care. When you work in healthcare, you're working in the ED, you're working in urgent care, it can feel like everybody who's sick is in my office. But the truth of the matter is most people who get sick in the United States do not get care. Of 100 patients who become ill in a given month, 40 consider getting care. Most stay at home, just wait, and probably a very prudent thing. When you rash, your ankle hurts a little bit, often things go away. And of those 40 people, only 29 get care. So a lot of people are becoming ill and not getting care. The reason I brought this up in the context of telehealth is that if you make care really convenient, more patients might seek input. And given that convenience and more options, more patients are going to get care. And again, we can decide whether that care is useful or not, but this driving up utilization has been the major concern and the reason that there has not been full continuation of telehealth moving forward here in terms of permanent expansions. Is this really happen? We don't know across the board. I'll tell you that some research that we and others have done prior to the pandemic, for example, for acute respiratory illness, found that 88% of the visits were new utilization, were additive, and that there was a net modest increase in spending, even though the telehealth visits were a lot cheaper than emergency department visits and physician office visits. Those savings from substitution were outweighed by this additive care. Have we seen that during the pandemic? Have we seen a big surge in visits? So far, no. If we look through the end of 2020, we'll still see that visits in 2020 were still below baseline. And so whether this is a theoretical concern about increase in utilization and increase in spending, or is this a true concern, is something we're going to continue to debate and will drive that policy conversation. I also just want to, I touched upon this, but I also want to emphasize, should we even be judging telemedicine based on its impact on spending? Are we talking about high value applications, people receiving specialty care or improved chronic illness management? We want this, but we don't want what some policymakers are worried about, where they're seeing unnecessary follow-up visits for laboratory for visits, or visits to discuss lab tests, or visits for colds where we're not providing a lot of value. Let me now turn to another key aspect of what's driving the debate about the future of telehealth, which is the impact on disparities of care. These are some pieces that we've published, and others have obviously expressed this. A lot of concern that because to have a video visit in particular, you need to have both the technology and the ability to use that technology to have that video visit. And while we hope that telehealth can narrow the existing disparities in the US healthcare system, there have been concerns that the people who can do video visits will be those who are wealthier, better educated, and this could widen disparities in the US healthcare. Has that really borne out? I wanted just to say that in terms of access to the necessary technology, there we do see substantial differences. This on the right is the fraction of Medicare beneficiaries who lack digital access in terms of either having a smartphone with a data plan, or a computer or a iPad or device at home. And this is broken down by patients by the percentage of federal poverty line. This is one of those duh findings. Those who are less than 100% of the poverty line, roughly half of them did not have the digital access, and as income goes up, it's most of those people get access. We also see really important differences by race and ethnicity, concerning differences. However, and this is one of the positive things we've seen, is that when we actually look in the Medicare data, as well as I'll show you some data from other places, we have not seen big differences by race and ethnicity in terms of the fraction of Medicare patients who use telemedicine. In anything, we see that among disadvantaged minorities, the use of telehealth is higher. We do see big differences between rural urban status, where rural communities, much less use of telehealth. This is also echoed in other work using commercially insured data, where basically urban enrollees are more commonly, but among in counties with more minorities, we actually see, or how would I say this, counties with a larger fraction of the population being white saw less use of telehealth, controlling for these other factors. And this has also been echoed in the literature. Some studies showing some differences, other studies showing not. But this issue of rural-urban divide is very, very clear in all the studies that have been done on this topic. So I think it's a really important question that we'll be facing, and a question that a lot of people are struggling with, is that is the use of telehealth going to narrow the disparities in the US healthcare system, or potentially widen them, and how do we address that? And that comes to this question that I get asked by clinicians all the time: well, what about the phone visits? When we look at the Medicare population, I noted for you that over half of them have had a telemedicine visit since the start of the pandemic. But how have they accessed it? Roughly 9% of them, of the total population, have had only phone calls. Over 30% have had video calls, and more than 11% have had both. And this is the group that I think people are worried about most. And it really is raising this question and ongoing debate about phone visits and certain populations who can, that's the only way they can access it. The questions that have been is people recognize it's been an important role in providing access during the pandemic, but those who have raised concerns that they're more prone to overuse. You might be aware that we've had a number of concerning fraud cases that have been using telephone visits, and also the concern that they might provide inferior quality. And we might lead to a two-tiered healthcare system where the rich get video visits and the poor get phone calls. And is that a problem, and how do we address that? I wanted to touch upon a third area of ongoing debate at the state level and the federal level that relates to telemedicine, which is related to licensure. For over 100 years in the US healthcare system, we've had a very basic rule that a physician must be licensed where the patient is located. That never really was an issue. You had a clinic in San Diego, a patient comes in from Nevada or Arizona and comes to your clinic, and they're in California and you're licensed in California, and so you take care of them and everything is fine. And then telehealth really, in particular during the pandemic, really challenged that issue. Maybe less of an issue in California or Southern California, but in many states or many areas where people are living near state borders, it's become a real barrier. In particular, if you look at the Washington, D.C. area, where you have D.C., Maryland, and Virginia, and people are moving back and forth across that border so fluidly, does a clinician need to be licensed in all those three areas, those states, Maryland, DC, and Virginia, or for UPenn, for example, where they're sitting right across the border from New Jersey? It's become a real barrier for those clinicians to provide care if they had to be licensed in all the states. Early on in the pandemic, most states passed laws saying, look, you know what? We're not going to worry about that. If you're licensed anywhere in the country, and you're in good standing in a state, you can take care of patients in our state. But unfortunately, over the summer of this year, most states started pulling back on those. And we've seen a lot of news stories and so forth about how these restrictions on licensure have really limited access for patients. And again, in particular, in communities where people are right across state, a city lives right on, sits right on the state border. And it's created really silly rules in this piece. It was a piece about a cancer patient who was getting her care in Massachusetts, but lived in New York State. And she, her oncologist said, look, you have to be in Massachusetts when I provide your care. So instead of having a visit in her home in New York, she had the option of driving 2.5 hours, pulling over at a rest area and doing a video visit in her car, because that she now physically was located in Massachusetts. And so because of the silliness of those rules, that kind of situation, people have had some really active debate within states about whether we should change this. A bunch of states have passed new legislation in the last couple of months to try to allow people, states, providers from outside the state to provide care, as well as other states have created new licensures that you can provide telemedicine visits. I have to say that these states have moved forward, but in most other states, including California, there's been so much opposition to this idea from the physician community, with concerns, and we can discuss what those concerns are, but really about, is this a good system where out-of-state clinicians can provide care to our residents? And so we'll see how this plays out over the course of the pandemic, as we move forward in the pandemic. So I wanted to wrap up a little bit before we turn to Q&A about where are we headed with the future of telehealth. I've outlined some regulatory issues and so forth, but what is it going to look like? I already, I wanted to first highlight that the current way we've thought about healthcare for so long has been, at least when I'm in training, I go through my training thing about visits and how do I bill an E&M visit and what are the different codes and criteria I need. But when we think about telehealth, it's really, that's really a visit-based model. But as we increasingly embrace phone calls, portal messages, We see a lot of companies providing the ability to provide text messages. We're doing remote patient monitoring. We're monitoring people sometimes 24/7. We've moved from a way where we pay on visits to numerous touch points. But the current payment system doesn't work for that. We get paid on RVUs and we have to have a certain number of visits. What we need to move towards is a system where we're paying providers almost like a monthly fee to take care of their patients as best as they see. And they can use any of these modalities because billing for each of these things is very expensive. It's a ton of administrative pain for clinicians, and it's also very costly. Some have estimated that every time we submit a bill for an E&M visit, it costs our healthcare system $20 just to get it administered, plugged in, deal with the health plan, et cetera. If you're talking about payments for something like a portal message or a text or patient monitoring, where you're only paying $20, it isn't worth it. And so that administrative burden has become a huge issue. And it's also a pain for clinicians to kind of remember, how do you bill for all this stuff? And so that's really pushed our way to try to do capitated models. We are seeing that has not progressed that far, but it's also been interesting to see a number of new companies that have emerged saying, look, we're going to provide primary care in a very, very different model. You pay us a monthly fee, and instead of having visits like this, we're going to do this all virtually. And we're going to do it using mostly phone calls, portal messages, texts, and saying, look, we can have so many interactions with the patient that we can take better care of our patients with chronic illness, give patients better access, and we're going to cut off all that administrative fees because we're just going to be paid on a monthly basis. This is Oscars. This is a picture from Firefly Health, which has garnered a lot of traction here in Massachusetts. I also wanted to touch upon, when we talk about the future of telehealth, about who the heck are we talking about? I think most people are thinking about the existing providers, our clinics, our hospitals, our big health systems. But I want to acknowledge that there is just so much money and energy and venture capital funding going to huge numbers of startups. And this is just a teeny list of the different startups that exist for things from behavioral health, oncology care, fertility, diabetes, and other metabolic issues, where all these private companies have emerged out there, and they are saying we can provide the care better than a UCSD or my own health system at Beth Israel or others. And when we think about where the future of telehealth is, are we talking about telehealth delivered by one of the existing health systems or these companies? Because these companies are growing so rapidly, it'll be a real challenge in terms of those two, potentially clashing in terms of who is trying to recruit our patients, and also raises all sorts of concerns about coordination across all these different providers that a patient can now get care from. But it's happening. Over 90% of large employers have introduced some form of telemedicine option for behavioral health, because their patients can't get into their existing providers, and so they're trying to provide a new way of accessing care. So I'll just wrap up here a little bit with, where the heck are we going? As I've hopefully has been clear over the course of this talk, is that we just don't know. There's a great uncertainty on next steps. I noted how health systems are really in a quandary and taking very different routes. I think where the policy consensus is we just have to kind of kick the can down the road and do a temporary expansion. For example, the Medicare Payment Advisory Commission has recommended to Congress that we continue the current expansions of telehealth for 1 to 2 years, and then pay for telemedicine at a lower rates. And then what we should do is just collect a lot of information and figure out where this telehealth is working or not, and really whether these concerns about increased spending are valid or not. And you're seeing a number of, I think, traction for that idea, both at health plans, at the federal level, at states. This is some of the state level legislation that's passed in the last couple of months, or this year, about ways that people are expanding telehealth, at least temporarily. So let me stop there and just emphasize the key takeaways. Lots it's been a very dramatic and unprecedented shift in terms of how care is delivered to digital health or telehealth during the pandemic. A lot of face validity that telehealth has been key to maintaining access, but a lot of uncertainty about where the clinical benefit has been greatest and potentially where it hasn't been helpful. And also this concern about spending. Uncertainty, lots and lots of uncertainty on where we're headed, the issues of spending, disparities, and also who are we talking about? Are we talking about telehealth delivered by the existing health systems or these telemedicine only companies? And lastly, how are we going to address licensure if we really want to give patients access? I think there's the QR code if you want to do that, but maybe I'll stop sharing and turn to Q&A.
Dr. Mehrotra, thank you so much for that really thought-provoking presentation. We have a question from one of our outstanding chief residents, Mark Jiang. He said, thank you for this riveting talk. You touched on the challenges of providing care through telemedicine across state lines. Could you comment on the role you foresee telemedicine playing in global medicine?
Yeah, no, it's when we think about it, and when we, at least in the not short term.
Dr. Mehrotra, sorry, there's some interference with your microphone. It's sounding garbled. Can we just maybe have you mute and then unmute? We'll try again.
How's it now? Is it better?
Still weirdly.
Was it fine throughout the talk, or was it garbled throughout the talk?
No, it was fine throughout the talk. I would have told you.
That's weird. That's weird. Let me try.
That's better. It's perfect now. Thank you. Continue.
All right. Okay. So, one of the things is I'm going to address the specific question about global health in a second, but let me actually just turn to this bigger idea that, when people have talked to me about telehealth, and look, this is way in the future, but it really challenges what a UCSD is. Right? Like, if, my health system, I'll just stick with mine. Beth Israel Deaconess, we see ourselves a leading academic institution treating the patients within Eastern Massachusetts and, the local outlying areas. Telehealth is like, why would you ever think of yourself as that? Why don't you think of yourself as we have a great group of gastroenterologists for biliary disease. Why aren't we the biliary disease providers for the world? And similarly for UCSD in terms of your areas of expertise also. And so there's not much limiting that. There are some obviously practical stuff that's going to limit that in terms of what's available and not. But it does really raise that possibility that can happen. You already are seeing that to some degree. You see some of those private telehealth companies go to employers who have an international presence, like a Google, and say, look, Google will provide the same care for your for your employees in Indonesia and the United States and in Europe, and will provide that care and will address all the licensure issues. So you're already seeing that movement. Now, that sounds all great. The licensure issues and how we regulate that are very complicated. Google obviously wants its employees to get the best care, and licensure sort of serves as some proxy that they are getting that care that they need. And we have right now, it's unclear how that's going to play out.
Thank you. From Dr. Parker, one of our faculty members, thank you for your talk. What do we know about the rural-urban divide in telemedicine? Is it broadband access, hardware, computer literacy, other, or all?
Yeah. I feel like on a multiple choice question, and I will now choose, as we all learn from taking our standardized test, all is usually the right answer. And in this particular case, it is the right answer. Yeah, I think there's a lot of different things playing out there, but let's just go through them one by one. First is that in many rural communities, the ability to get broadband is very limited. It's very expensive. Second, in contrast to the types of employees that are out there. There's less of an emphasis that, that everyone's going to have a computer in their home and have that ready access. They're not on Zoom all day to the same degree. And that also leads to the computer literacy aspect of it. And we also know that rural communities have, on average, lower educational levels, and so may have less facility. You can see from the infrastructure package that the Biden administration passed, as well as other things, huge amount of investment, more than $100 billion being spent to at least expand broadband in rural communities. We will see if that has an impact, but obviously the concerning aspect that isn't going to have an impact next month or next year. It's going to take a while. And so this rural-urban divide, I think, is a very concerning, because we already at baseline had substantial differences between rural communities and urban communities in access to care, and this is probably going to make it worse.
Thank you, Dr. Mehrotra. And from one of our VA chief residents in quality and safety, a related question that you've touched on a bit. Is there any active work, federal grants, national projects, et cetera, to increase access to telehealth for rural regions in the US? As a chief resident in quality and safety going into endocrinology, this is something I might pursue more seriously as a career. I know you touched on the Biden administration. Is there other work being done in this area to try to improve this access?
Yeah, so there is efforts in terms of, first, the one that everyone recognizes is the broadband aspect. But certainly having broadband available in your community isn't enough. You need to have the technology. I don't know if many of your patients still call them that, but there's the Obama phones, Obamacare phones that people would get. And so there's an issue of, can we expand access either by paying for the smartphone or smartphone broadband coverage? And so that's been another area of investment. I think where there's a less certainty is that there's a recognition that we need to also help our patients and get them through that process. In so many of our clinics, we have social workers, which help our patients with housing and food, but we now need digital facilitators. People who are really digitally savvy don't typically go into healthcare. That's not the typical thing, but now we need those people in healthcare to help our patients. And so there's all sorts of experimentation, both by policymakers and health systems, to sort of set up those types of facilitators. I have not seen a lot of evidence or rigorous research about what's most effective, but I think that if we do figure that out, those is where the dollars need to go. But in terms of where work needs to happen, we all recognize there's patients who need those tools and that training, but how most effectively to do so remains unclear. I imagine you have something within your health system. I don't know, Simranjot, if you've had anything at the VA too.
Yeah, so actually the VA has been really proactive about providing devices to veterans to facilitate video visits and telehealth. And we're really fortunate that one of our faculty members here at the VA San Diego, Leonie Hayworth, she actually oversees and is in charge of the efforts for the nation in terms of the VA improving VVC and telehealth access. So we've been really lucky in that respect for our patients, at least at the VA.
Yeah, I think one point I'll bring back to is this whole thing about phone visits. I think we'd all agree that we'd prefer a world where we didn't have to worry about this and that all of our patients could have a video visit. And so there is a lot of ideas about, okay, can we do this as a short-term thing? We'll pay for phone visits for a couple of years while we as a society try to ensure that all our patients have access to video. Then I do hear an important aspect of this, which is video clearly superior? There's obviously big advantages of it, but we also have patients who prefer not to do video and either are uncomfortable with it or in an environment where they can't have it. And so we don't really know what that right balancing act is between the two.
Completely agree with you. I definitely have many a video visit that gets converted to a phone call for a variety of reasons at the last minute with my patients. Dr. Mehrotra, from Dr. Seltzer, one of our faculty members, we have one more question. Thank you for your talk. Are there problems establishing and maintaining rapport with patients with telemedicine? I would think giving bad news to patients in person is more humane than over the phone.
We've done a bunch of projects where we've interviewed a variety of different clinicians about how they see video visits and phone calls and in-person visits, and how do you choose, right? We're all making this up on the fly, right? No one went into medical school, and I didn't have a class saying this is when you should do X and this is when you should do Y, and here's rules of thumb. We've all sort of tried to figure this out. The question alludes to a very basic and common sense idea, which is that you don't want to do a more complicated and difficult conversation should happen in person. And that makes sense to me. Do I have evidence that that's the case? I don't have evidence of that. Maybe others do. However, I will also allude to the fact that the counter argument, maybe from people who really are telehealth big proponents. The first is that when you have a difficult conversation with, say, an older adult and you do it in person, or you do it via telehealth and all their family members are on from all over scattered around the country, you can you can have a better conversation and a complex conversation if that support structure is there, and telehealth facilitates that in a way that if that older patient was there alone in your clinic. The second idea that you sometimes hear about is that visits are a pain in the butt. And if you have 4 visits in a year, how much of 15 or 12 minutes each, how much of a relationship do you have? But I touched upon a little thing of all these touch points. If you have a lot of text messages, you have email, phone calls, and you're interacting with someone on a more frequent basis, maybe you can build that rapport in a better way, because it isn't just, say, 4 visits of 48 minutes in total over a whole course of a year. So these are some interesting tensions. Again, it makes sense to me, but we don't have consensus on what, and last point I'll say on that point is we did a study looking at psychiatrists and what they feel comfortable in person versus via video. And it was one of those things, you talk to one psychiatrist, you've talked to one psychiatrist. There is no consensus among that clinical field about what was appropriate. Some felt very adamant that the first encounter must happen via in person, and others are like, no, I think we can do this via video or a phone call, and they would explain the context. So I think even within clinical areas, we don't have consensus on what is sort of standard of care.
Thank you. And from Dr. Jacoby, when I deploy on disasters to another state, as a federal employee, I only need 1 state license, and it is recognized by the requesting state as part of an agreement for getting the response. Similar issues happen with the military. Why not have adjacent states agree to recognize state licenses for a small fee to cover tracking or agree to reciprocity?
Yeah, I will say that within the VA system, the same exists, that Simmer's and others who work in the VA can care for any patient within the VA system anywhere in the country through federal legislation. And there is basically, you just must be licensed in 1 state. I believe, and the nurses have also done that, where they also do automatic reciprocity. You're licensed in California, you can take care of patients in any other state. And I think that that's probably where we need to head as a physician community, where you're licensed in California, you're in good standing, and you can care for anyone in the United States. And there's going to have to be better transfer of information, malpractice lawsuits, et cetera. But those are solvable problems from my perspective. I don't think the current system of doing a lot of administrative barriers serves our patients well, and actually decreases access to care.
Excellent. Thank you so much, Dr. Mehrotra, for that really thought-provoking and timely presentation. We're so grateful to you for sharing your work with us.
No problem. And happy holidays to all of you. And thank you for taking the time.
Thank you. Happy holidays to our guests and our participants. We will have a hiatus from Grand Rounds for the next 2 weeks, and we'll see you again in January. Thank you. Take care. Thanks again, Ateev.